Why is it critical to implement individualized exercise protocols for patients with chronic obstructive pulmonary disease (COPD) a cardiac rehabilitation program? Discuss the physiological rationale and list key precautions when designing these protocols. Answer: exercise protocols for COPD patients must be individualized due to the variability in lung function, cardiovascular fitness, and muscular deconditioning in this population. COPD often leads to reduced oxygen saturation during exercise, necessitating careful monitoring to prevent hypoxemia. Additionally, these patients may experience increased dyspnea, limiting exercise capacity. Key considerations include physiological rationale, improving oxygen utilization. Aerobic exercise enhances oxygen efficiency, reducing the ventilatory burden. Mitigating muscle wasting. Resistance training helps counteract muscle wasting commonly observed in COPD, improving quality of life. Exercise reduces dyspnea and fatigue over time. Key precautions: monitor oxygen saturation using pulse oximetry. Supplemental oxygen may be necessary if SPO drops below 88%. Avoid high-intensity activities that trigger acute bronchospasm. Incorporate longer warm-ups and cool-downs to accommodate respiratory limitations. Relevant guidelines: American College of Chest Physicians Act and American Association of Cardiovascular and Pulmonary Rehabilitation (OCPO) recommend an initial evaluation of pulmonary function and incremental increases in exercise intensity. How can motivational interviewing my techniques be effectively applied to improve adherence to a cardiac rehabilitation program? Answer: motivational interviewing is a patient-centered counseling method aimed at eliciting and strengthening intrinsic motivation for behavior change. The four guiding principles of my rule are crucial. Resist the writing reflex. Avoid correcting the patient's behavior directly to reduce defensiveness. Understand the patient's motivations. Use open-ended questions to explore their values and goals. Listen with empathy. Reflective listening builds rapport and clarifies the patient's perspective. Empower the patient. Support autonomy by reinforcing their ability to make positive changes. An example: for a patient hesitant about exercise, instead of saying "you need to exercise more," ask, "what changes in your daily life might help you feel healthier?" This opens dialogue and encourages the patient to take ownership of their rehabilitation journey. Mr. Taylor, a 62-year-old stroke survivor, has residual hemoptysis on his left side. He's referred to a cardiac rehabilitation program due to concurrent heart failure. What steps should be taken to integrate stroke rehabilitation principles, particularly neuroplasticity, into his exercise program? Answer: for Mr. Taylor, a dual focus on cardiovascular improvement and neuroplasticity is essential. Stroke rehabilitation principles emphasize task-specific training and repetitive practice to promote neural reorganization. Steps to integrate neuroplasticity: task-oriented training, encourage activities mimicking daily tasks, e.g. walking with weight bearing on the affected leg to restore functional movement patterns. Progressive resistance training, strengthen the paretic muscles while ensuring joint integrity. Aerobic exercise for cardiovascular health, use low-impact modalities such as a stationary bike ensuring stability. Constraint-induced movement therapy, SIMT, encourage use of the affected limb to overcome learned non-use. Neuroplasticity principles, apply intensive, repetitive, and challenging exercises tailored to the patient's ability. Precautions, monitor for fatigue, overuse of the unaffected side, and cardiovascular instability. Explain the modifications needed in exercise prescription for a patient with chronic kidney disease (CAD) to minimize risks during cardiac rehabilitation. Answer: patients with CKD require tailored exercise plans to prevent exacerbation of their condition while improving cardiovascular health. Considerations for CKD: anemia, reduced oxygen carrying capacity limits exercise intensity, electrolyte imbalance. Risk of arrhythmias necessitates close monitoring of potassium levels. Bone disease, avoid high-impact exercises to prevent fractures. Modifications: use low-intensity aerobic activities like walking or cycling. Incorporate stretching and low-load resistance training for flexibility and strength. Monitor blood pressure pre and post-exercise to identify signs of volume overload or hypotension. Relevant guidelines: the National Kidney Foundation in Kiev advocates a conservative approach with a focus on patient tolerance and safety. What are the best practices for using digital tools to improve health literacy among cardiac rehabilitation patients? Answer: digital tools such as mobile apps and online videos are effective for enhancing health literacy when used strategically. Personalization: tailor content to the patient's reading level and language. Interactivity: Use apps with features like reminders for medication and exercise tracking. Engagement. Recommend videos and infographics to simplify complex medical information. Validation. Ensure tools are evidence-based and approved by professional organizations like the AACVPR. Example: a video demonstrating safe exercises for post-surgical patients can alleviate anxiety and promote adherence. Relevant guidelines. The U.S. Department of Health and Human Services emphasizes clear, user-friendly digital communication for patient education. How should a cardiac rehabilitation program address musculoskeletal issues that may impact a patient's ability to participate in physical activity? Provide examples of common conditions and specific strategies for modifying exercise programs. Answer: musculoskeletal issues such as osteoarthritis, low back pain, or previous joint injuries can significantly affect a patient's participation in a cardiac rehabilitation program. A comprehensive approach is needed to ensure both cardiovascular and musculoskeletal health are addressed effectively. Common musculoskeletal conditions: osteoarthritis (OA) causes joint pain and stiffness, particularly in weight-bearing joints. Low back pain (LBP) often due to muscular weakness or improper posture. Previous injuries, e.g. ACL tears, can cause limitations in range of motion and strength. Modification strategies: low-impact exercises. Use aquatic therapy, stationary cycling, or elliptical machines to reduce joint strain. Strength training: focus on strengthening muscles around affected joints to improve stability, e.g. quadriceps strengthening for knee OA. Range of motion (ROM) exercises: incorporate gentle stretching and flexibility exercises to improve joint mobility. Pain management: utilize techniques such as thermal therapy or TNS transcutaneous electrical nerve stimulation to reduce discomfort during exercise. Precautions: avoid high-impact activities that exacerbate joint stress. Gradually progress intensity to avoid overloading musculoskeletal structures. Ensure proper posture and technique to prevent further injury. Relevant guidelines: American College of Sports Medicine (ACOM) and AACVPR recommend individualized exercise prescriptions for patients with musculoskeletal issues to enhance participation in cardiac rehabilitation. Ms. Roberts, a 55-year-old cardiac rehabilitation patient, is struggling with consistent adherence to her exercise program. Her husband, Mr. Roberts, is highly motivated and wants to support her. How should you involve Mr. Roberts in her rehabilitation plan using motivational interviewing techniques to enhance her adherence? Answer: motivational interviewing can be extended to family members to help them support the patient effectively. Involving Mr. Roberts in a supportive and non-judgmental way can empower Ms. Roberts and improve adherence. Steps to involve Mr. Roberts: establish a collaborative relationship. Engage in a conversation with Mr. Roberts to understand his concerns, motivations, and perceptions about his wife's rehabilitation journey. Use open-ended questions to help him identify how he can best support her. E.g., what are some ways you think you could help her stay motivated? Enhance motivation through empathy. Acknowledge both the patient's and the spouse's feelings. For instance, say, "I can see how much you care about her health, and I know it can be frustrating when progress is slow." Reflective listening allows Mr. Roberts to feel heard and understood, which reinforces his motivation to help set family-centered goals. Help them set small, achievable goals together, such as completing a walk together after dinner or reminding Ms. Roberts to attend a rehabilitation sessions. Reinforce positive actions, such as verbal praise when Mr. Roberts supports the exercise routine. Precautions: be sensitive to family dynamics and ensure that Mr. Roberts does not take on the role of the therapist, which may increase stress for both parties. Encourage realistic expectations about progress and avoid placing blame if goals are not met. What specific considerations should be made when prescribing exercise for a patient with chronic kidney disease (CKD) undergoing cardiac rehabilitation? Discuss the rationale behind each modification. Answer: patients with CKD face several challenges during exercise, including limited exercise capacity, anemia, and electrolyte imbalances. Prescribing exercise for this population requires careful attention to avoid exacerbating renal dysfunction and to optimize cardiovascular outcomes. Key modifications: monitor for anemia. CKD patients often experience anemia due to decreased erythropoietin production, which impairs oxygen delivery during exercise. Exercise intensity should be low to moderate to avoid excessive cardiovascular strain. Oxygen saturation levels should be closely monitored. Electrolyte imbalances. CKD may cause disruptions in potassium and sodium levels, increasing the risk of arrhythmias. Regular monitoring of serum electrolytes is critical. Avoid exercises that could induce dehydration, such as vigorous high-intensity interval training, here, especially if the patient is on diuretics. Bone health considerations. CKD can result in secondary hyperparathyroidism, leading to weakened bones. High-impact exercises should be avoided to prevent fractures. Focus on resistance exercises that target muscle strengthening without loading the skeletal system excessively. Dialysis considerations. If the patient is undergoing dialysis, exercise should be avoided immediately before or after dialysis, as patients may be more fatigued or hypotensive at these times. Precautions. Exercise sessions should be shorter in duration but more frequent to build tolerance gradually. Monitor blood pressure closely during exercise to identify signs of fluid overload or hypotension. What are the most effective tools for improving health literacy in cardiac rehabilitation patients, and how can these tools be integrated into a rehabilitation program? Answer: improving health literacy in cardiac rehabilitation is critical to ensuring patients understand their conditions, treatment plans, and the importance of adherence. Key tools and strategies include brochures and printed materials. Use clear, concise, and visually appealing brochures that outline exercise guidelines, medication instructions, and lifestyle changes. These materials should be written in plain language with appropriate graphics to simplify complex medical concepts. Mobile health apps. Apps can track progress, provide reminders for medications and exercises, and allow patients to set goals. Interactive features, such as videos on proper exercise technique, can be useful for reinforcing learning. Videos and online resources. Short educational videos that explain common cardiovascular conditions, the rehabilitation process, and the role of exercise can engage patients more effectively than written material. Videos should focus on demonstrating exercises, explaining benefits, and addressing common patient concerns. Patient-centered education sessions. Offer group education sessions where patients can ask questions, express concerns, and learn through discussion. Utilize teach-back methods where patients repeat the information they have learned to ensure comprehension. Precautions. Ensure materials are culturally and linguistically appropriate for diverse populations. Regularly update digital tools to reflect current guidelines and ensure they remain user-friendly. What are the primary indications and contraindications for performing a graded exercise test (GXT) on a cardiac rehabilitation patient, and how should these factors influence clinical decision-making? Provide examples. Answer: a graded exercise test (GXT) is used to evaluate a patient's cardiovascular fitness, assess symptoms of cardiac conditions, and determine exercise prescription parameters. Indications for GXT include the following: diagnostic assessment of suspected coronary artery disease (CAD), preoperative evaluation for high-risk surgeries, risk stratification for exercise programs in cardiac rehabilitation, functional capacity assessment for exercise prescription. Contraindications include acute myocardial infarction or unstable angina, severe heart failure with decompensated symptoms, severe arrhythmias or uncontrolled arrhythmias, severe hypertension e.g. systolic BP 200 mmHg or diastolic BP 120 mmHg, uncontrolled diabetes, particularly with ketosis. The clinical decision-making process must involve evaluating the patient's medical history, current health status, and any contraindications. The test should only proceed if the risks are outweighed by the potential benefits and a rehabilitation program is tailored accordingly. Explain the FITT principle and how it is applied in exercise prescription for cardiac rehabilitation patients. What adjustments should be made for high-risk patients or those with comorbidities? Answer: the FITT principle consists of 4 key components used to create a personalized and effective exercise program. Frequency F refers to how often a patient should engage in exercise, typically 3-5 times per week for cardiovascular benefits in cardiac patients. Intensity I, the level of effort required during exercise, often determined by heart rate reserve HR, percent max, or Borg RPE. Scale: for cardiac patients, moderate intensity 4060 per HR is generally recommended to avoid excessive strain. Time T refers to the duration of each exercise session, commonly ranging from 20 to 60 minutes, depending on the patient's tolerance and health condition. Type T, the mode of exercise e.g. walking, cycling, treadmill, chosen based on patient preferences and functional capacity. Adjustments for high-risk patients. Frequency and intensity. These may be reduced for patients with severe comorbidities like uncontrolled diabetes or heart failure. Time, exercise duration may be decreased, especially in initial sessions, and gradually increased as the patient's tolerance improves. Type, low-impact exercises such as cycling or swimming are preferred to reduce joint strain. Why are warm-up and cool-down protocols essential in cardiac rehabilitation, and what guidelines should be followed for each phase to ensure patient safety? Answer. Warm-up and cool-down protocols are essential to gradually prepare the body for exercise and prevent injury or adverse cardiovascular events. They promote circulation, reduce the risk of arrhythmias, and enhance muscular flexibility. Warm-up duration. Typically 5-10 minutes of low-intensity aerobic activity to increase heart rate and blood flow to muscles. Intensity. The intensity should be low enough to avoid sudden strain on the heart. Often 40-50% of HRR. Rationale. This prepares the cardiovascular system for the increased demand of exercise and reduces the likelihood of arrhythmias or other cardiovascular issues. Guideline. According to AHA and ACSM, gradual progression from light to moderate intensity should be followed. Cool down duration should last for 5-10 minutes with a focus on reducing heart rate gradually through low intensity aerobic activity intensity. The intensity should be similar to the warm-up, around 40-50 per HRR, and gradually decrease. Rationale. Cool down helps in preventing orthostatic hypotension and allows the body to return to its baseline state without sudden cardiovascular stress. Guideline. Stretching exercises should also be incorporated to improve flexibility and promote muscle relaxation. Mr. Harrison, a 58-year-old male, recently underwent coronary artery bypass surgery (CAG) and is now enrolled in a cardiac rehabilitation program. His physician has cleared him for low-intensity exercise. What key considerations should be factored into his exercise prescription, and what initial exercise program would you recommend? Answer. Mr. Harrison's exercise prescription should take into account the following. Post-surgery recovery. After CABG, the focus should be on low-intensity exercise initially to avoid placing excessive strain on the heart rate monitoring. Intensity should be determined based on heart rate reserve, HRA, or the Bolgar-PE. Scale, warm-up, and cool-down. These are critical for improving blood flow and preventing complications. Duration. Start with shorter durations, 10-15 minutes, and gradually increase as his tolerance improves. Given that he is post-surgery, the program could begin with low-impact activities such as walking on a treadmill or stationary cycling at 40-50% of HRR. Over time, duration and intensity can be increased based on his progress, always staying within the range of moderate intensity. Explain the role of nicotine replacement therapies (NRTS) and counseling techniques in smoking cessation for cardiac rehabilitation patients. How should these be integrated into the rehabilitation program? Answer. Nicotine replacement therapies (NRTS), such as nicotine patches, gum, lozenges, or inhalers, provide a controlled dose of nicotine to reduce withdrawal symptoms and cravings during smoking cessation. For cardiac rehabilitation patients, NRTS help reduce relapse by alleviating physical addiction, support lifestyle changes as nicotine dependency is often a barrier to long-term smoking cessation. Counseling techniques include cognitive behavioral therapy (CBT), helps patients identify triggers and develop coping strategies. Motivational interviewing encourages patients to express their reasons for quitting, improving commitment. The integration of NRT and counseling is effective in creating a comprehensive smoking cessation plan, improving adherence, and promoting cardiovascular recovery. Guidelines from CDC and AHA recommend a combination of pharmacologic treatment and behavioral counseling for best results. How should dietary guidelines be tailored to promote heart health in cardiac rehabilitation patients? Discuss the importance of macronutrient balance and heart-healthy eating patterns. Answer. In cardiac rehabilitation, dietary guidelines should focus on promoting cardiovascular health by emphasizing balanced nutrition and healthy eating patterns. Key elements include macronutrient balance, carbohydrates. Prefer complex carbs such as whole grains, which help in managing blood sugar levels and provide fiber. Proteins. Emphasize lean proteins, e.g., fish, poultry, legumes to support muscle repair and recovery without adding excess saturated fats. Focus on unsaturated fats, e.g., olive oil, avocados, while limiting saturated and trans fats, e.g., red meats, processed foods to lower cholesterol levels. Heart healthy patterns. Follow the Mediterranean diet or DASH diet, which includes high amounts of fruits, vegetables, and healthy fats. Limit sodium intake to reduce hypertension risk. These dietary guidelines should be individualized based on the patient's nutritional status, weight goals, and comorbid conditions in line with AHA guidelines. Explain the role of stress reduction techniques like mindfulness, yoga, and relaxation exercises in the rehabilitation of cardiac patients. How do these techniques improve cardiovascular health? Answer. Stress reduction techniques are vital in managing the psychological aspects of cardiac rehabilitation, helping patients manage anxiety, depression, and emotional stress, all of which can negatively impact cardiovascular health. Mindfulness encourages patients to stay present, reduce stress, and promote relaxation. It has been shown to lower blood pressure and improve emotional well-being. Yoga combines physical postures, breathing techniques, and meditation to enhance flexibility, reduce muscle tension, and regulate the autonomic nervous system. Relaxation exercises, techniques like progressive muscle relaxation or deep breathing exercises help lower sympathetic nervous system activation, reducing stress and preventing excessive increases in heart rate and blood pressure. Incorporating these techniques into rehabilitation programs improves mental health, aids in stress management, and enhances heart rate variability, reducing the likelihood of cardiovascular events. What strategies can be employed to enhance patient adherence to a cardiac rehabilitation program? Discuss the importance of goal setting and progress tracking. Answer. Enhancing patient adherence is essential for the long-term success of cardiac rehabilitation. Key strategies include goal setting, setting specific, measurable, achievable, relevant, and time-bound, SMART goals ensures patients are engaged and motivated. For example, a goal of walking 30 minutes per day for 5 days per week is measurable and provides clear direction. Progress tracking, regular monitoring, and feedback, e.g., using exercise logs or wearable fitness devices, show patients their improvement over time, increasing motivation. Visual tracking tools like graphs or charts can help reinforce positive behavior. Social support, involving family members or support groups, can improve accountability. By setting realistic goals and tracking progress, patients feel empowered to continue rehabilitation, enhancing overall outcomes. Explain how smoking cessation and dietary changes are integrated into behavioral and lifestyle interventions for cardiac rehabilitation patients. How should these interventions be personalized? Answer. Smoking cessation and dietary changes are fundamental components of a cardiac rehabilitation program. Both require personalized approaches to ensure effectiveness. Smoking cessation, tailored interventions including pharmacotherapy, nicotine patches or bupropion, and counseling, CBT, or motivational interviewing are key. These strategies should be customized based on the patient's smoking history, readiness to quit, and psychological profile. Dietary changes. Each patient's dietary needs should be personalized based on comorbidities like diabetes, hypertension, or hyperlipidemia. For instance, patients with type 2 diabetes may need a low carbohydrate intake to manage blood sugar, while those with hypertension may require reduced sodium intake. Personalization ensures that patients are more likely to adhere to the intervention, improving both physical and emotional outcomes. What considerations should be made when designing an exercise prescription for high-risk cardiac rehabilitation patients? Answer. For high-risk cardiac rehabilitation patients, e.g., those with heart failure, severe coronary artery disease, or arrhythmias, exercise prescriptions should be cautious and closely monitored. Initial assessment. Conduct a thorough evaluation, including stress testing and risk stratification, to determine the patient's capacity and potential contraindications. Intensity. Start with low-intensity exercises, the walking, light cycling, based on the rating of perceived exertion, RP, or heart rate reserve. Supervised training. Exercises should be done under the supervision of healthcare professionals, especially during the initial phase. Monitor vitals, e.g., heart rate, blood pressure during sessions. Progression. Gradually increase intensity and duration as tolerated. Include interval training for improving aerobic capacity once stability is established. Individualized plan. Tailor the exercise to the patient's specific condition, e.g., low-impact exercises for arthritis or weight-bearing exercises for osteoporosis. Discuss the role of psychological support in cardiac rehabilitation. How can addressing psychological needs improve outcomes? Answer. Psychological support is crucial in cardiac rehabilitation as many patients experience anxiety, depression, or stress after cardiac events. Addressing these issues can improve adherence, quality of life, and clinical outcomes. Psychotherapy, Cognitive behavioral therapy (CBT) can help patients identify and change negative thought patterns related to their health. Counseling, providing education about their condition and recovery process, reduces fear and uncertainty. Support groups, connecting patients with peers who have had similar experiences, fosters a sense of community and shared understanding. Mind-body techniques. Practices like meditation, mindfulness, and relaxation exercises reduce stress and improve emotional resilience. By managing mental health effectively, patients are more likely to engage fully in rehabilitation and adopt long-term healthy behaviors. Beta blockers are commonly prescribed for patients with cardiovascular conditions. What is the primary mechanism by which beta blockers affect exercise tolerance, and what considerations should a cardiac rehabilitation professional keep in mind when working with patients on beta blocker therapy? Answer: beta blockers work by blocking beta-adrenergic receptors, primarily the beta-1 receptors in the heart, which reduces heart rate, contractility, and myocardial oxygen demand. This is beneficial for managing conditions like hypertension, heart failure, and angina, but it also affects exercise tolerance by limiting the increase in heart rate during physical exertion. This can make it difficult for patients to reach their target heart rate during exercise, potentially limiting the effectiveness of cardiovascular training. Considerations for cardiac rehabilitation professionals: monitoring heart rate. Since beta blockers prevent heart rate from rising adequately during exercise, heart rate should not be relied upon solely to gauge exercise intensity. The use of perceived exertion scales, such as the Borg rating of perceived exertion, is often more effective. Dosing adjustments. Rehabilitation professionals should be aware of the patient's prescribed dose and its potential to cause excessive bradycardia. Exercise modifications. Exercises should be adapted to ensure safe and effective participation, with intensity adjusted based on the patient's tolerance and perceived exertion rather than heart rate. What are the risks and benefits of using antiplatelet drugs such as aspirin and clopidogrel in post-myocardial infarction in my patients, and how should a cardiac rehabilitation professional assess the risk of bleeding in these patients? Answer: benefits. Antiplatelet drugs such as aspirin and clopidogrel are commonly prescribed after myocardial infarction to prevent thrombosis by inhibiting platelet aggregation. This reduces the risk of recurrent MI or stroke and improves long-term outcomes in coronary artery disease patients. However, these drugs increase the risk of bleeding, including gastrointestinal bleeding or hemorrhagic stroke. Cardiac rehabilitation professionals need to be mindful of this, particularly when patients are involved in activities that could cause trauma, e.g., resistance training or high-impact activities. Assessment of bleeding risk. Medical history. A thorough review of the patient's medical history, including any history of peptic ulcers, gastrointestinal bleeding, or stroke, is essential. Monitoring symptoms. Patients should be monitored for signs of bleeding, e.g., easy bruising, prolonged bleeding after injury, or black stools. Exercise modification. High-risk activities should be avoided, and more controlled, lower-impact exercises should be emphasized. Mrs. Peterson, a 65-year-old woman with congestive heart failure (CHF), has been prescribed a diuretic to manage fluid overload. She is referred to cardiac rehabilitation to improve her cardiovascular fitness. During a routine session, she complains of dizziness and lightheadedness. What could be the underlying cause of her symptoms, and how should the cardiac rehabilitation professional respond to this situation? Answer: potential cause. Mrs. Peterson's symptoms of dizziness and lightheadedness could be a result of electrolyte imbalances, dehydration, or hypotension due to the use of diuretics. Diuretics increase urine output, which can lead to significant fluid loss, reducing blood volume and causing hypotension, especially when standing up. Orthostatic hypotension. Electrolyte imbalances, particularly low potassium, hypokalemia, can also contribute to dizziness, weakness, or arrhythmias. Response: immediate action. The cardiac rehabilitation professional should stop the exercise session, ensure the patient is safely seated or lying down, and monitor vital signs, e.g., blood pressure, heart rate. Referral: refer Mrs. Peterson to her physician for evaluation of her diuretic therapy, including possible adjustments to dosage or electrolyte supplementation. Patient education. Educate the patient on recognizing signs of dehydration or electrolyte imbalance and the importance of maintaining hydration and a balanced diet rich in potassium. ACE inhibitors are often prescribed in patients with heart failure to prevent cardiac remodeling. What is the mechanism by which ACE inhibitors exert their effect on cardiac remodeling, and what role should a cardiac rehabilitation professional play in monitoring these patients? Answer: ACE inhibitors block the enzyme angiotensin converting enzyme ACE, reducing the production of angiotensin I, Angiotensin I normally causes vasoconstriction and stimulates aldosterone release, which can lead to fluid retention, increased blood pressure, and harmful remodeling of the heart muscle. By inhibiting ACE, these drugs help to lower blood pressure, reduce fluid retention, and prevent the pathological remodeling of the heart muscle that can worsen heart failure. Role of cardiac rehabilitation professionals: monitor vital signs. Regular monitoring of blood pressure is crucial as ACE inhibitors lower blood pressure, exercise progression, ensure exercise intensity is adjusted based on the patient's functional status and response to medications, as ACE inhibitors can improve exercise tolerance over time. Education: inform patients about the benefits of the drug in improving cardiac function and preventing further deterioration. A 55-year-old male patient, Mr. Harris, who recently had a myocardial infarction, shows signs of depression and anxiety. He expresses reluctance to participate in his prescribed cardiac rehabilitation program. What psychosocial interventions should a cardiac rehabilitation professional consider, and how can they improve Mr. Harris's adherence to the program? Answer: psychosocial interventions. Screening: use standardized tools such as the PHQ-9 for depression and the GAD-7 for anxiety to assess the severity of Mr. Harris's symptoms. Cognitive behavioral therapy (CBT). Referral to a mental health specialist for CBT can help address the underlying negative thought patterns contributing to his depression and anxiety. Group therapy. Group therapy within the rehabilitation program can provide emotional support and foster a sense of community, helping reduce feelings of isolation. Family involvement. Encourage family involvement to provide emotional support and ensure that Mr. Harris has the necessary resources at home to manage his condition. Improving adherence. Education. Explain the role of rehabilitation in improving both physical and mental health outcomes. Gradual progression. Start with low-intensity activities to build confidence and prevent overwhelming the patient. Positive reinforcement. Provide encouragement for small achievements to build motivation. Statins are widely used for their lipid-lowering effects, but they can have side effects that impact patient compliance. What are the common side effects of statins, and how should a cardiac rehabilitation professional address these concerns with patients? Answer: common side effects of statins: muscle pain, myopathy. One of the most common side effects, which may cause patients to feel fatigued or unable to exercise. Liver dysfunction. Statins can increase liver enzymes, potentially leading to liver damage in some patients. Gastrointestinal issues. Nausea, constipation, or diarrhea can also occur in some patients. Cognitive effects. Some patients may experience memory loss or confusion, though this is rare. Addressing concerns. Education. Discuss the importance of statins in reducing cardiovascular risk and the need for regular monitoring of liver function and muscle health. Exercise adaptation. If muscle pain is a concern, advise lighter exercise and monitor for any worsening of symptoms. Communication. Encourage open communication about side effects so that adjustments to medication can be made in collaboration with the patient's physician. How can family caregivers play a critical role in the success of a cardiac rehabilitation program, and what steps should a rehabilitation professional take to involve them effectively? Answer: role of family caregivers. Family caregivers can provide emotional and practical support, help with medication adherence, and assist with physical activity at home. They often play a pivotal role in encouraging the patient to adhere to lifestyle changes and rehabilitation exercises. Steps for involvement. Education. Offer education to family members about the patient's condition, the goals of cardiac rehabilitation, and the importance of their support. Support groups. Encourage family caregivers to participate in support groups to share experiences and gain insights into effective caregiving strategies. Active participation. Involve caregivers in the rehabilitation process, such as attending sessions or assisting in the home exercise program. What are the potential risks of electrolyte imbalances, e.g. hypokalemia, hyponatremia in cardiac rehabilitation patients, and how should exercise intensity and duration be adjusted for these patients? Answer: risks of electrolyte imbalances. Hypokalemia, low potassium, can lead to arrhythmias, muscle weakness, and fatigue. Hyponatremia, low sodium, can cause nausea, confusion, and even seizures in severe cases. Both conditions can be exacerbated by excessive fluid loss during exercise. Adjustments to exercise. Monitor symptoms. Regularly assess for signs of fatigue, muscle cramps, or dizziness during exercise, which may indicate an electrolyte imbalance. Hydration. Ensure that patients are adequately hydrated, but not overhydrated. Exercise modifications. Reduce the intensity or duration of exercise if electrolyte imbalances are suspected. Heart failure patients often experience fluid overload. What are the key strategies that a cardiac rehabilitation professional should employ to help manage this condition during exercise? Answer: key strategies. Daily weight monitoring. Encourage patients to monitor their weight daily to detect early signs of fluid retention. Exercise guidelines. Engage patients in moderate intensity aerobic exercises that promote circulation and help reduce fluid retention, fluid restriction, and diuretic use. Coordinate with healthcare providers to adjust diuretic therapy as needed based on the patient's fluid status. Breathing exercises. Teach patients breathing techniques to improve oxygenation and reduce pulmonary congestion. What role does stress management play in cardiac rehabilitation, and what strategies should be used to reduce stress in patients recovering from cardiovascular events? Answer: role of stress management. Chronic stress is a significant risk factor for cardiovascular disease, and it can hinder recovery in cardiac rehabilitation patients. Managing stress can lower heart rate, reduce blood pressure, and improve overall cardiovascular health. Strategies for reducing stress. Relaxation techniques. Teach relaxation methods such as deep breathing, progressive muscle relaxation, or guided imagery. Cognitive behavioral therapy (CBT). Refer patients to CBT to help address stress and anxiety. Physical activity. Encourage regular physical activity, which has been shown to reduce stress levels and improve mental well-being.